Great, thanks. So I'm Robbie Allen, third year. So I kind of stretched the meaning of procedure lecture. So thanks to the procedure team for letting me talk on this. I think it's something that we don't really get enough time devoted to. So hope you enjoy. All right, cool. So get right into it. So no financial disclosures except receiving a couple of beers from Dr. Kendall for doing the Zoom interviews in the class. Speak louder. Okay. Thank you to the Procedure Day team, as well as Dr. Wiener for his tox and farm expertise, and D'Souza, who is one of my mentors. So the overview of what I wanted to discuss today. So what are the goals of sedation? What are some of the causes of agitation? And then what are the different tools that we can use in the ED? Okay. So warning, so this is just my personal take. I'll try to provide some evidence for this. So I'm not going to say, I think different people have different approaches, especially in terms of medications. For example, toxicologists like to use benzos and some of us like to use antipsychotics. So I'm not saying that one approach is the best, but more of a reminder for us to think about this topic. So getting into it. So what's our first goal? So first goal is sedation is to get them to sleep, right? So these are some patients from the ED that were adequately sedated. All right. So our next goal, right, is speed. So in the ED, we're all about speed, right? So you want to get them sedated as fast as possible. On the other hand, is harm, right? So we want to do sedation fastly, effectively, but also there are harms related to oversedation. So you have kind of the balance of three. And the last goal, so what do I mean by this? So not all patients in 18 hallway belong in 18 hallway. So I guess how do you guys evaluate patients in 18 hallway? So we all know what kind of patient we're thinking about. I'll give my honest opinion. What we've all done, at least I've done, guilty of, is you have a patient with a chief complaint of alcohol intoxication, right? So you do a thorough exam, right, which means that you're at a distance, you're kind of pressing on a random limb through their 4 layers of clothing. You give them like the drink sign to like indicate that they did drink. And then you walk away, right, empty up in the comments, and then remember to come back to the patient for sign up, right? We've all done it, right? What are the harms of it, right? What are some things to consider? So you notice here, I'm doing the QR codes, by the way. So if you scan it, it will give you the link to the article. So anyways, so this is the first article I came across. So this was from Hennepin. So you'll notice Dr. Driver is one of the notable researchers in EM. Anyways, so this study was a 5-year observational study. Basically, they looked at patients with presumed alcohol intoxication, presumed ultramental status from alcohol intoxication. Okay? And so the cool thing about this study is from Hennepin, they standardly do breathalyzer tests there. So they actually can see who actually was drunk or had some alcohol on board and who wasn't. So they looked at 30,000 patients over a 5-year period. Of these patients, about 6% had negative ethanol levels. All right, so it's some useful information at baseline to think about. Obviously, it might just vary from place to place. Of those patients that had a negative alcohol level, about 10% of those, so 0.6 of the overall population, had either trauma or medical causes that contributed to their ultramental status. And then of those patients, the total, only 200 patients ended up being admitted, and I think 0.06% of the total population was admitted to the ICU. So I guess my takeaway from this is that just be careful in your approach. This is just for the one population that alcohol intox, but most of the time you will get it right, in that there probably isn't anything dangerous going on, but you are going to get burned if you don't evaluate patients properly. So this is just my reminder that think about the agitated patient broadly. Don't anchor on chief complaint, like I've definitely done. So how do you do this? So how do you distinguish between the patient who is just drunk versus who might be sick, right? I don't have a good answer. So this is like from Where's Waldo. It's one of my things from my childhood. So it's kind of like the Waldo is your sick patient, and this is your sea of non-sick patients. All right. So again, how do you do this? How do you find that Waldo? Right. Some people call this the spider sense, the spidey sense. People call this your gestalt. Obviously, ideally, we'd have a patient that's fully undressed, has vitals regularly, has finger sticks, but practically, it's not practical. So this is something that we have to develop a skill about who do you kind of developing a gestalt about who could be sick, but also just trying to remember not to anchor. All right. So this will be now my transitioning. This is from the halftime show. So the rest of the talk, I'm going to give some cases and some practical advice about how do we treat agitated patients, how do we sedate them. So this is the first case. So 33-year-old female comes in after eating a brownie. All right, so first step, pregnancy test, right, of course. After that, right, so then they're a little anxious appearing. So this first case, this is really your patient who is agitated, meaning they're getting out of bed, but they're redirectable, right? You can go lead them back to their bed, right? If you offer them a sandwich, they'll accept. So how would you approach this patient? For me, I think it's kind of stepwise approach for any agitated patient. So I think the first step, like I mentioned, you can do verbal de-escalation. That could be in a lot of different things, but it just means talking to them. Maybe that means having a family member sit at their bedside, and that could be enough. If that doesn't work, there's also chemical sedation. So there's medications. So for this patient who is not causing a major disturbance, I think I would start with oral medications. So oral medications tend to have a more favorable profile, less side effects versus IM or IV medication. So there's a bunch of different options. There's lorazepam, risperidone, Lanzipine, quetiapine, haloperidol. The point being is that just think about what medication you want to offer. You can always give more. It's hard you can't take it away. So just be careful about your dosing. But for this first patient, I would start with oral medication after your stepwise approach, giving them food, etc. How about this next patient, right? Another real patient who I got consent for the photos to be included. So this is a 29-year-old male who, keep in mind, they drink all the beer, right? This patient's now a little bit more disruptive. So they appear intoxicated, but they're disruptive, right? You offer them a sandwich, but they're not going back to their room. So how would we approach this patient? Again, I think stepwise. So the first thing is, showing force, right? This is your verbal de-escalation. What do I mean by that? So the main thing here is safety. So this is talking about verbal de-escalation. Unfortunately, with 30 minutes, I don't have enough time to dedicate to this topic. It'll probably be its own hour-long lecture. Main things to think about is that you don't want to be trapped behind a patient. So always thinking about where you are positioned. So keep a safe distance, right? It is recommended generally to have a show of force, meaning you may have security or hospital police there just to show the patient and for your own safety that they're not going to, basically for your safety, okay? And that sometimes might be enough. And that may be able to redirect them to go to their bed, all right? You can offer them oral medication, but sometimes they won't accept. So now what's the next approach? Right, so this is where I would consider intramuscular medication. So how do we administer intramuscular medication? So there's three main areas. So it would be your deltoid, your anterior thigh, or your superior lateral quadrant of your gluteus region. Some other things to consider. So why IM versus IV? So right, IV is more dangerous. This is an agitated patient, so there's a danger to the staff who's putting in the IV as well as the patient. So generally, you want to do one shot, right? So IM would be the way to go, okay? If they need the IV, obviously you can put that after they're sedated. What else? This is one study I linked to that shows that it's safe to give intramuscular medication through clothing, right? Something to consider. All right, so I would say IM is the way to go. So what medications? So this is a B52 that I Googled. So B52, This kind of stands for this classic cocktail we think about, Benadryl, 5-Haloperidol, 2-Ketamine. So let's talk about the different medications. So the first one is haloperidol. We've all used it. It's our first generation antipsychotic. It blocks the dopamine receptor. Some adverse events to think about. Main thing would be extrapyramidal symptoms. It's still rare, but not uncommon. So that's sometimes why it's co-administered with like an anticholinergic, like a Benadryl. And also some other side effects is hypotension and QTC prolongation. So as far as dosing, for monotherapy, you can actually use 5 to 10. I know we always give 5 here, but you can give up to 10. It's been studied. And what's some of the issues with it? I would say the main thing is that it's slow in onset. So the issue is that you give your 5, and then your nurse is looking at you. Everyone's looking at you, and nothing happens. So then you redose them, and now they're snowed, and it's a sign out, which is okay, right? But one of the main issues for Haldol is efficacy. So we mentioned our first goal is, or what second goal is speed. So I'd say one of the drawbacks for Haldol is not as fast as some other medications. So what about this next medication? So now we're talking about Droparadol. So some of the interns, maybe other people may not have heard of this because we don't use it, right? So what is it? It was developed in the 60s, was approved for use in 1971. So it has a long safety record just by using it for so many years. As far as the comparison to haloperidol, also shows some studies, but basically compared to haloperidol, it's actually faster in onset. For the dosing, the monotherapy dose would be 5 to 10 milligrams, or 5 milligrams IV. Some other uses, like haloperidol, there's some, of course, for headache and nausea. Actually, one of the main uses was for anesthesia to prevent post-op vomiting. It even helps for vertigo, which I thought was interesting. So what happened? Why come we're not using it? So in 2001, this was the black box warning that was released. So I highlighted it. The main thing, there was some cases, specifically there's 273 cases that were reported of torsades to point. So I'm on talk right now. So Dr. Hoffman made the point that torsades should not be spelled with an S. So there should be only an S after points. So that was interesting. Or you could say TDP. So the main thing that you see here is that they want you to get an EKG before administering and have to be monitored. So because of this, it was taken off the market. All right. There's a lot of controversy and maybe QAnon theories about why it was taken off. Maybe not QAnon, but one of the things is you're being skeptical is that the cost, right? The cost. Thinking about at 2000 when it was taken off the market, had 30% of the market share for an antiemetic, right? Now we all use Zofran. So what's the difference in the cost between Zofran and Droparadol? About 2.5 milligrams costs $2, which is the dose we use for antiemetic, whereas 4 milligrams of Zofran costs $150. So just something to consider. All right, so moving on. So what's the common thing on the list on the left? So these are all black box warning medications, right? So point being is that we use a lot of these medications. So black box warning doesn't mean that you can't use it. You just have to be aware of why there's a warning. All right. On the right, hopefully you can see this. This is from crediblemeds.org. It lists, it's free to register. Basically, these are medications that we commonly use. I kind of crop the ones that we use that are affiliated or associated with TDP or Torsade. So there's a bunch of medications on here that we commonly use. Zofran, one of them. So the point being is that just because there's a black box warning doesn't mean you can't necessarily use it. But let's look at the evidence that does Droparadol actually prolong the QTC. So this is a paper from the anesthesia literature, which shows that Droparadol does have a dose-dependent effect and a pretty fast effect on prolonging the QTC. So Droparadol definitely prolongs QTC, but just because a medication prolongs QTC does not mean they're going to develop Torsade, right? So we'll kind of leave it at that for now. What do our guidelines recommend about using Droparadol in the ED? So the first is a study in animals in 2015. This just showed there's only 1,000 patients. It basically showed that there was no episodes torsades that are noted. So it's obviously underpowered for such a rare episode, but there's a bunch of studies, a bunch of clinical evidence that shows that it's a very rare thing. Does it necessitate that we take it off the market and not use it? What about, so AEM put a statement out in 2015. So they kind of chickened out, I would say. They said for doses less than 2.5, you don't need an EKG. But this doesn't really help us because the doses that you're giving for agitation are much higher than that. So it's a little bit of a gray area. So right now there's no clear position statement saying that you don't need an EKG before giving it. There's a lot of clinical data suggesting it's safe medication. So I'll leave it at that for now. All right, so transitioning to more of the commonly used medications. So this is midazolam or Versed. So just talking about, you typically classically use B52, we also use Ativan. So what's the difference between Ativan and Versed? So I think a lot of us may know this from treating people with seizures, that if you don't have an IV, I guess the classical teaching is to give Versed. The reason being is that Versed had a faster onset intramuscularly than Ativan. As far as dosing, for monotherapy, so using a single agent, we use 5 to 10 milligrams. So a lot of these medications, it's pretty similar dosing, so it's kind of easy to remember. I mentioned toxicologists like benzos. I don't really have enough time to go into different causes of agitation, but there's a lot of indications where benzo would be your first choice, especially with like withdrawal syndromes. The issue with Versed and benzos as a class is that there is a small, narrow therapeutic index, meaning that you get adverse events or side effects at the margin where you're treating. So, for example, the main thing you're worried about is respiratory depression. So the issue is that if you're going to give this patient Versed, you kind of have to monitor them. So they can't be in 18 hallway off the monitor. So just something to consider. So you can also use it as combo therapy. So you can use Droparadol 5 and midazolam 2, Lanzipine 5, midazolam 2, or you can give your Haloperidol 5 and Versed 2. So something to consider. All right, so what's some of the data? So this is from the DORM study in 2010, published in Annals. So this is a blinded RCT of adult patients. So the two groups were, there's 3 groups. It was 10 of midazolam versus 10 of Droparadol, or a combo of 5 and 5, Droparadol and midazolam. It was a pretty small study, only 90 patients. The primary outcome was time to sedation. There was no difference between the two groups, but it was Versed required additional sedatives more than Droparadol. Okay, so there's no difference between the two groups. Versed required more additional sedatives, but there were more adverse events in the midazolam group, 8 versus 2. Most of these were all respiratory depression. So, and of note, there's no episodes of torsade, right? But again, this is underpowered for that outcome. So, moving along, the next medication is olanzapine. So this is now our 2nd generation antipsychotics, or atypical. Also works for headache and nausea, like Droparadol and Haloperidol. One thing to consider is that it might be harder for our nurses to administer because it takes some time to reconstitute the medication. Something to consider. Again, the dosing is 5 to 10 milligrams IM, so easy to remember as monotherapy, or you can give it as a combination medication. Again, we got to worry about respiratory depression. So let's look at another study. So conveniently for this presentation, this one looked at Droparadol, olanzapine, versus the control was actually placebo, but they did receive immediately Versed. So basically consider control Versed in this population. So this was 2013 study out of Annals. So again, ED patients, about 300 patients. The dosing was actually 5 of Droparadol IV versus 5 of olanzapine IV. All right, so the primary outcome, again, time to sedation. Droparadol and olanzapine were faster than Versed, and there's no difference in adverse events. Again, no episodes of torsade. So just some evidence to support that maybe Droparadol or Lanzipine might be the way to go. All right, so the last case I want to talk about is the other end of the spectrum. This is your dangerous patient, right? So this is a patient that's pretty rare that we see, but it's someone that you think has either immediate life threat, maybe they're hypoxic that's causing them to be agitated, or they're dangerous to staff, right? So this is someone that you want to sedate rapidly. So this is when I'll talk about ketamine. Again, a little bit of a controversial medication. This is a slide from Ruben Strayer, talks a lot about ketamine. Point of the slide is that with ketamine, there's a spectrum of effects you can get. So at low dosing, you get an analgesic effect. For our agitated patient, we want to be on the left side of the screen, so the dissociated dose. So at a higher dose, you're going to get a reliably dissociated state. One of the things that we've seen is the reemergence phenomenon. So when you're on the left side of the slide at the dissociated state, as you come back and metabolize the medication, you go through this partially dissociated state. And so this is when they might be more aware and might have this reemergence phenomenon. So that's why we might get Ketamine. So we might give another medication to prevent this reemergence phenomenon. So that aside, there's a lot of side effects with ketamine that you have to be aware of. We use it a lot commonly for procedural sedation, so we should be aware of it. So main things would be increased hypersalivation, laryngospasm. We also think traditionally is that having a lot of sympathomimetic effects, so tachycardia, hypertension. But there is some studies that show that in sick patients, you actually can get hypotension. Point being is that this patient, if you're giving ketamine at a high dose, so the dose would be 4 to 6 milligrams per kilogram intramuscular, or you can just give 500 milligrams. They need to be monitored. For us, would be in CCT. They have to have this procedural sedation, so they have to be on monitor, right, and getting vitals regularly. So this is, again, not a patient that you're going to stick an 18 hallway off the monitor. There's a lot of other things that we might have heard about. There's controversies about ICP, intraocular pressure that's largely been debunked. So people might mention that there's a theoretical concern about giving ketamine for patients with psychiatric disorders. It's still largely been debunked, but it is controversial. So I'll leave it at that. So again, one last study. So this was published this year, 2020, in AGEM. So this was an open label study. So there's risk of bias with that. So again, agitated patients in the ED. So they compared ketamine versus your Haldol 5 and 2. So a little bit of an odd choice of comparison. And their endpoint of this was sedation at 5 minutes, right? And so, not surprisingly, ketamine was more effective at 5 minutes, and the effect carried out through 15 minutes. So 66% of patients at 15 minutes were sedated with ketamine versus only 7%. So point being that 5 and 2 is pretty slow. So I would say, and then as far as side effects, there are more side effects traditionally, classically with ketamine. You can see here there's more hypertension, tachycardia. There was equal rates of intubation in this group. So I will leave it at that. So the last thing, you notice that I didn't really talk about physical restraints. I would say the reason for that is that I think, if I'm being honest, I think we probably overuse physical restraints. We probably improperly use it. So I would argue that we should only use physical restraints after giving chemical sedation, and patients should never get physical restraints without chemical sedation. The reason being is that physical restraints, while it might achieve safety for us, there's a lot of risks associated with physical restraints, right? And it's also not treating their agitation. So I'll kind of leave it at that. There's a video here, this is from MCRIT, about how to apply restraints. So you can watch that. The main thing you have to worry about is that you don't want them to aspirate, so you make sure you elevate the head of the bed. And yeah, you can watch the video. We'll talk about how to apply it more safely. Trevor, he asked, does anyone know if Droparadol and Pyxis? The answer is no. It's non-formulary at both sides of the street. So in summary, what I hope to achieve from this lecture, so mental triage, right? So we have a hard job in the ED is that we have to take care of a lot of patients, and it is one of our jobs, or the main goals of residency is to learn to identify the sick from the non-sick. A lot of people who are not EM doctors like to criticize this as triage doctors. I don't think that's I don't think that should be an insult. I think that's almost a compliment that we are able to rapidly identify who's sick versus who's not sick. So think about not anchoring on who's just drunk versus who may have something else that's potentially sick. Think about potentially from moving on from 5 and 2. I'm not advocating for a specific drug, but just kind of think critically about what medication you can administer. And lastly is Dr. G's role. So again, this is probably the patient's like worst day coming to the ED agitated. So let's make sure we treat their agitation and so that they can get through this episode and treat them with respect. All right, and then these are my quarantine buddies, my wife Sarah, and the dog Lola. Share my references. Okay.
Any questions, comments? I guess the only thing I'd say that I kind of learned the hard way too is, which I think now works very well, is if there's a person who has psychiatric disease and they're somewhat redirectable, offering them their home antipsychotics. And they usually are actually most of the time, sometimes they'll take that, and instead of having to go down the route of IM, IV things, just giving them their home antipsychotic seems to be actually something that works for me. Yes, go ahead.
And in CPAP, we usually really very often use Aldol and Ativan and also combinations. So, from the 2 and a 1 or just a 2 for elderly person, even less sometimes, like 1 milligram IM of Aldol, up to 10 milligrams IM of Aldol, and Ativan from 1 milligram to 3, sometimes 4, depending on physiology. And so what we add the Benadryl to the classical Haldol and Ativan anymore for some worries about sedation. So usually we just use those two. Those are really habits, but they work pretty well. It's like kind of what a lot of those patients get in the CPAP. But the population is different from the quite different actually. And Zyprexa, we never give with Ativan IM concerns over sedation. So that's also kind of a habit that is considered to, not go well together and possibly produce over sedation. The same thing with Thorazine, that we do use quite a bit. We wouldn't give Ativan. So those are prescribing habits on the other side. Because we don't really have monitoring, or it would be kind of pretty quickly disastrous once we get falls in respiratory distress.
Awesome.
Chris asked in the chat, should we have a code ETOH? What does that mean?
Chris, do you mind elaborating on your question?
Sure, I've heard other residencies have a code ETOH when if someone triages alcohol intox, will be brought in, then a physician and a nurse has to go to the bedside and undress the patient and quickly evaluate them to make sure that we're not missing any sick, presumed alcohol intoxication patients.
Oh, that's actually pretty cool. Yeah. Bruce, that sounds like a great QI project. I actually agree. Yeah, good idea.
Bruce said he's actually going to make it his senior project before graduating. I'm excited to see the results.
I don't know if Dr. Brewster is on the chat, but I think I don't know if our nursing colleagues would be super happy with that. I mean, we have to handle like our sepsis codes first, so just adding another code might, along with like we have alarm fatigue, might have code fatigue. But I like the idea of undressing patients.
Good idea. All right, thanks,
Robbie.